Today, we're taking a close look at a very sophisticated treatment for severe maxillary atrophy, zygomatic implants. More specifically, we're going to explore a novel anatomical classification system that was designed to prevent one of the most critical complications of this entire procedure, accidental penetration of the patient's orbit. All right, here's how we're going to break this down. First, we'll set the stage by defining the clinical challenge and the major surgical risk involved. Then, we'll dive into the clinical study that proposed a new safety framework, the ZOF classification system. And finally, we'll wrap up with the study's key findings and what they really mean for surgical practice. So, let's start with the fundamental clinical problem. We're talking about severe maxillary atrophy, which poses a massive challenge for any kind of prosthetic rehabilitation. This is where zygomatic implants have really come into their own as an effective graftless solution. Now, unlike conventional implants that absolutely need enough bone in the maxilla, zygomatic implants do something different. They use the very dense zygomatic bone for their anchorage. This creates a really stable foundation for prosthetics, and it means patients can often avoid those complex and frankly very lengthy bone augmentation procedures. But, and this is a big but, a procedure this complex isn't without some very significant risks. The location of the surgical site itself introduces a major potential complication, and that is the central focus of the research we're looking at today. The number one risk here is accidental orbital penetration, either by the drill or the implant itself. And given the incredibly vital structures inside the orbit, any kind of iatrogenic damage can lead to severe consequences. This makes meticulous, careful, preoperative planning absolutely non-negotiable. This view of the anatomy really illustrates the challenge perfectly. As you can see, the target for the implant, that zygomatic bone, is sitting directly next to the orbital floor. This close proximity demands an intimate, detailed understanding of each patient's unique anatomy to ensure the surgical path is a safe one. So, to tackle this risk head-on, a group of researchers conducted a clinical study. Their goal was to develop a framework that could make implant placement safer, especially in situations where surgeons are working without advanced surgical guidance systems. The study looked at 81 patients, with a mean follow-up of almost 9 years. Now, what's really crucial here is that 100% of these implants were placed using a freehand technique. That detail is so important because it removes digital guidance from the equation and puts all the emphasis squarely on the operator's anatomical knowledge and preoperative planning. To really analyze the outcomes, the patients were sorted into 4 distinct groups. You can see in these CBCT scans the different configurations they used. It ranged from 2 zygomatic implants combined with conventional ones, all the way to cases where 4 zygomatic implants were used for a full arch rehabilitation. And this brings us right to the key innovation from the study, a brand new anatomical classification system. It was designed specifically to boost surgical safety by actually quantifying the risk of orbital penetration before the surgery even begins. This system is built around a parameter they named the zygomatic orbital floor, or ZOF for short. You can think of it as a very specific measurement taken from CBCT scans that gives a number to the concavity, or the undercut, of the orbit's lower and lateral walls. Now, what's so elegant about this is just how straightforward the measurement is. Using a frontal view on a CBCT scan, the ZOF is simply the vertical distance, marked here as x, between the most lateral point of the orbital wall, which is point A, and the lowest point of the orbital floor, point B. That's it. And based on that one simple measurement, the researchers established 4 distinct classes. Class I, which is 0 to 3 millimeters, is considered a flat orbital floor. And then it progresses all the way up to Class 4, which is any measurement over 10 millimeters, described as an extremely deep orbital floor. And here is the so what. The clinical application is direct and incredibly clear. A higher ZOF class, meaning a deeper orbital floor, tells the surgeon they must place the zygomatic implant lower on the zygomatic bone. This simple rule gives them a tangible guide for planning the osteotomy to maintain a safe margin from the orbit. Okay, so we have the system. Let's get into the clinical findings and see how this builds a case for this protocol. The study analyzed all the surgical outcomes and anatomical data to really validate how useful the ZOF system is in practice. One of the first major findings was related to a common complication inside the maxillary sinus. The data showed that using an intramaxillary placement pathway for the implants led to a statistically significant reduction in the rupture of the Schneiderlin membrane. This plot gives us a really clear picture of that exact finding. It's comparing the intramaxillary versus the extramaxillary placement right up against the incidence of membrane rupture. The difference you see here is statistically significant, which confirms that the intramaxillary technique is indeed safer for avoiding this specific sinus-related complication. The study also uncovered several other key points. First, and most importantly, there were 0 cases of orbital perforation, which strongly suggests the preoperative planning was effective. Interestingly, they found that a patient's ZOHF class doesn't depend on their age, but it did show significant anatomical differences between the left and right sides. They also found no correlation between the height and width of the zygomatic bone, which really underscores that a wide bone isn't necessarily a tall one, making the ZOHF measurement that much more critical. So the crucial takeaway is summed up perfectly in the study's own conclusion. The researchers state unequivocally that assessing the ZOF parameter is profoundly important for preventing orbital damage, and that it should be a standard measurement taken before every single zygomatic implant surgery. And this leaves us with a really compelling question. In an era where technologies like computer-guided surgery are constantly advancing, this study really highlights the timeless value of pure anatomical knowledge. It makes you consider the essential role that fundamental, accessible classification systems like ZOF still play in establishing a baseline of safety for every patient, regardless of the technology you have at your disposal.